Okay, so now we're going to transition from kind of these physical ailments to psychological complications after delivery that women can experience. And one of probably the ones you've heard most about as far as postpartum complications psychologically would be uh, the psychological complication of postpartum psychosis. Okay, so when we talk about mood disorders with women postpartum, it's really important to recognize what's normal and what's not normal. So most women, almost 3/4, experience some sort of mild depression or what we call baby blues. And some women get a little bit more serious, and then some have a very serious form that develops into a psychosis. And so kind of when I explain mood disorders to women, after they've had a baby, it's really a part of normalizing what they're going to feel. So it's very typical for someone to be very happy. They've had their baby, they love their baby, they love their husband or their boyfriend or whatever, their significant other, and they are embracing motherhood and they're enjoying it, and yet at the same time they feel a very hormonal surge of I have to cry. And that's a very normal experience. Most women will be tearful. It might be they watch a commercial from McDonald's and suddenly they're crying and they don't know really why they're crying. They just know that there's this immediate kind of emotional roller coaster that they're on. And that's really normal. When we look at that, that is the surge and the reduction suddenly of the progesterone and the estrogen, and suddenly their hormones are playing games with them. I kind of call it like a ping pong ball, right? It just kind of bounces around in there. And what I tell women is that if they feel like, okay, I have just cried my eyes out and I feel better, then it's probably just baby blues. That just means that they are feeling the emotional roller coaster of normal hormones. What I do worry about is when depression sets in like a fog, right? And it feels like it's a blanket that covers their house, their mood, their ability to care for themselves. Then I'm a little bit more concerned. At that time, I want them to kind of be checking in with their partner and saying, you know, am I right in this? Does this feel like this to you, that I just suddenly don't want to shower and I don't want to get up out of bed and I don't want to care for my baby? Is it actually incapacitating them to the point where they aren't caring for themselves or their baby, right? And so I really do worry a lot more about the woman who cries and then doesn't feel better. And how I kind of explain it to women and their significant others, because honestly, the significant others are usually the ones who notice first, right? And I try to empower them to have those conversations with each other and to call the provider and say, hey, I'm concerned about, you know, Julie, and Julie is having a really rough time since her delivery. She's tearful and she's not taking care of the baby and she's not showering. Is there any way that we can get her in for an appointment, and to advocate for her, right? For women, I tell them, you know, if you hate everybody equally and that isn't normal for you, then it's probably time to get concerned and to be talking to your provider about other options. And I, you know, kind of normalize it in the fact that oftentimes with the amount of hormones changing and surging, we sometimes have to treat people for depression for a short period of time so that they're better able to care for themselves and to cope with all of the changes that happen after delivery and all of these adaptations to their new roles as parents. So it's important that we help parents to recognize when there's an issue postpartum. But it's also important for us to recognize the importance of that, to really gain an appreciation that postpartum depression is nothing to kind of say, oh, it's probably going to get better, or it's probably nothing. It's not something to minimize. And as a care provider, we want to make sure we're understanding that there really is a huge implication, not just for the patient herself, but for her newborn, for her new family, for their adaptation to their roles, for attachment issues, for family integration. that sometimes it can get to the level where it really does threaten the safety, the well-being of either her or her children or her newborn or even her spouse. And that seems like, boy, that's almost a laughable matter until it's not. And the truth is that, a normal baby blues kind of period can transition into a postpartum depression. And a postpartum depression episode can translate then into a further deepening into mental illness or into a postpartum break or postpartum psychosis. So it's really critical that we help parents to recognize the symptoms, to not minimize it, but to explore what their options are, which may include medication. It may include having extra hands or support at home with childcare. And it may include therapy. It may include cognitive behavioral approaches. It may include, having a cleaning lady. That's kind of how I put it. Maybe there's just too many burdens on this mom. And sometimes there's a real chemical issue that's going on, or there's possibly the tendencies for familial mental illness suddenly get triggered by this extreme process and all of these extreme hormone fluctuations. And so, kind of if we look at postpartum psychosis and how we break it down, you can see we're going to get to this pie chart here in a moment. And you can see where in postpartum psychosis, there's actually a combination of symptoms. Now, it's not uncommon for a brand new parent to have increased difficulty falling asleep, right? Increased difficulty staying asleep, and difficulty with just adapting with mood swings and irritation. But as we travel into that spectrum of postpartum psychosis, you're really looking at they're seeing and hearing things. Something isn't right. They are hyperactive on occasion, and sometimes they're completely hypoactive. It just depends. But most often they're going to be irritable, they're going to be hyperactive, they're going to have sudden, intense mood swings that make no sense and maybe aren't linked to any sort of rational thought or process, right? Oftentimes they'll develop a real paranoia. They'll be suspicious. Everybody wants to take their baby. Somebody's poisoning their food, that sort of thing. And they may start to exhibit some delusional behavior. So they may start to have these strange beliefs and be expressing these strange ideas that don't necessarily align with reality. Sometimes they'll find that there's some difficulty communicating. So they may lose the ability to communicate in words and be effective at communicating. And this is something that is like a medical emergency, right? Because especially if someone's experiencing paranoia and delusions and they're seeing and hearing things and they're irritable and they've got severe mood swings, you're actually looking at a point of where they kind of disconnect from reality and they actually have the ability to harm someone, including their newborn, which may include drowning their newborn, which is horrible to think about. It may include stabbing a loved one. It may include all sorts of behaviors that are just completely unreconcilable with who that person is day to day. And so it is truly something that if you ignore all of the warning signs leading up to that, can lead to some really poor outcomes and tragic loss. Okay, so now we're going to touch on a topic that can be really difficult, and it can be difficult for us as care providers, and it can be difficult for us as human beings. It can be something that may trigger some emotions for some of us in our classes, and just realizing that we need to be sensitive and careful with ourselves and with each other. We are going to talk about fetal demise, or what happens when that baby is not born alive, or the baby is born alive and then dies, or how we cope and handle that. And I really call our job as a nurse is to help just gently guiding people through grief, right? We have that basic of psychology. We know that there's all these stages of grief, and there's denial and anger and bargaining And eventually people kind of start to come to terms with it. And we see the beginnings of that when we're interacting with patients who've had a fetal demise. It is not an easy topic or an easy part of the care that we deliver. However, it's a very important piece of the care we deliver. And it is crucial that we also take a moment to really acknowledge the fact that we are going to have an emotional response to a fetal demise, and that we may have a moment where we identify with that mother or another family member. I know now as a grandmother, I identify differently with my families when they have a demise. I really feel that grandmother's pain as well as that mother's pain, and that is additive to us as staff and as nurses. And so it's really important to also include self-care when we're talking about this topic, and when these occur on your shift, that you're also making sure that your entire team is caring for itself, that you are gentle with each other, that you don't let the pressures of a short shift or anything else affect how you interact, right? You really want to make sure that you're touching base with everyone on the shift and making sure that they're coping okay. So I think it's pretty obvious that grief is not simple. There's no one straight path through grief, and grief takes its forms in many directions and it's many paths. And just because one person is on this stage of their path and another is on another piece of the path, that eventually they won't converge, or that they're not coping well, right? And so there's a couple of different types. So there's anticipated grief, and this is really when we know that families know their child is incompatible with life, meaning that it's not going to live at all or for long outside of the womb. A lot of times these families are already have been grieving at home. They oftentimes will be very tearful. They look to their spouse, to their family for support. They've already initiated that support, usually prior to. And oftentimes because of this, because it's not something that is shocking or new to them, they're actually able to talk about this experience, and they actually usually need to at some point. Oftentimes they will hold that infant, and they'll keep that infant, and they'll keep it at the bedside, and they actually bond with the deceased infant. And that is a crucial piece of grief, because in order to fully grieve, we have to have a relationship to grieve the loss of a relationship. And so oftentimes they'll come to the hospital already with a plan in place. They may know which funeral home they want, or what sort of services they may want or need. And oftentimes they'll determine prior to coming in about when they want to go home. I want to come in, I want to have the induction of my demise, and then I'm going to go home as soon as I possibly can, or I want to spend a night, or they'll have plans. I want to have an epidural, or if they have to have a cesarean, they'll make plans for, and I'm going to go home day one after that. And just because grief is anticipated doesn't mean that people are going to go smoothly through it. There are still going to be issues as nurses that we're continually kind of grappling with, really. And it's important for us as nurses to kind of differentiate the anticipated versus the unanticipated, because oftentimes those who are anticipating are much more able to interact with you and to be able to answer questions and to not be basically compartmentalizing as much, because grief is really additive, right? And so as people explore that strange forest of grief, if they've started together prior to getting to the forest, they're much more likely to stay in eyesight and earshot of each other. Once we start to get into an unanticipated scenario, so some sort of thing goes wrong, that they have a normal healthy fetus and suddenly they come in and their cord has tangled and it's knotted or something and the baby has passed. There is a definite period of denial. There is a definite moment of, this is not happening to me, and no, I want to go home. And there is this moment where they are overwhelmed in the onslaught of emotion of grief, that so much so that they shut down almost. Very common to see anger, right? To see that they are, this is unfair, I didn't do drugs and my baby is dead. I didn't, my sister didn't want a baby and she, had this baby and I want this baby, I've worked for this baby, I've done in vitro, I've done whatever, and now I don't get this baby. And I'm so angry with the world, right? They're angry with anyone who's pregnant. They're angry with anyone who walks in their room. And that is a really typical reaction. And it's okay for us as nurses to say, anger is a completely normal response. We want them to know that they're not, unusual and that they're not bad people for feeling angry, right? Oftentimes, shortly after that, they'll go through a period of withdrawal where they may not want to talk, they may not make eye contact, they may be tearful, or they may be silent. They may be rolled over and facing the wall. They're going through such agonizing emotional pain that sometimes they numb it completely out and they just withdraw from the world. Some will cry and wail, and some will have relatives who cry and wail. And these are important things that we need to respond to as a normal cultural response, right? Each person individually is going to respond how they need to in that moment, and we are just there as observers and as tour guides, is basically effectively kind of helping them through each stage of grief as they get there. Sometimes the spouses may not talk. They may have nothing to say. There may be buried anger or resentment, or there may be blame, or there may be, and these are important things for us as nurses to help them to engage back into spoken word and to help them to realize that there's, no fault here and that there's nothing that they probably could have done to change the outcome of this. Oftentimes, if grief is unanticipated and it's a sudden episode, oftentimes they'll be resistant to holding the infant, and that, is something that you can't get back 3 years later. There's no other going back through this later on, so you want to keep reapproaching. I know yesterday you didn't feel like you wanted to hold your baby. However, if I bring your baby in, I'm going to wrap your baby in a warm blanket, and I'm going to have a hat on your baby. And you describe what they're going to see, what they're going to hear, and what they're going to feel. The baby maybe is very pale if they haven't looked at their baby, or it's got blood around the lips. And the more you can kind of describe what they're going to see, hear, and feel, the more that they can kind of grasp and envision themselves holding the baby, the more likely they are to actually hold that baby. And that's really crucial because, again, in order to properly grieve, there has to be some establishment of this baby existed. And part of that existence is holding that baby, right? And although not all people are going to hold their baby, most of them will. And there's a lot of ways we can help gently lead people through that. Oftentimes when people have unanticipated grief, they just come in with no plans. They have absolutely no idea. And so then our role as a nurse is really to share what are the plans that could happen. What are their options here? And they aren't always ready for this, the shift they deliver. Sometimes this is the night shift nurse who comes on after the day shift nurse and has to walk them through this at 2 in the morning. When they start to ask questions, that's the time to start pulling out, here are some of the things they need to plan on. And if you really get 2 or 3 shifts down and they're not making any plans, then we need to start that conversation and help them make plans. I know you probably don't want to talk about this. However, we really do need to make some arrangements for your infant, and you may be saying, okay, here are the options of, we can send the baby off for an autopsy. We can do chromosomal studies. We can certainly utilize whatever funeral home is around. This funeral home provides free cremation, and this funeral home provides this. And then there's usually a resource book somewhere on the unit that will give you some of this information. And also at the same time, we know they want to get away from us as quickly as possible. And so sometimes there's some need for us to fill in those blanks and to mark those check boxes that we know those plans so that they really can go home. And sometimes we have to say, so that you can go home tomorrow, I need to get some information from you on how we need to, deal with this. Another important component of what we do as nurses when we have a grieving family is really in supporting them. And in that support, you really do have to take a moment and acknowledge their loss when you first come in for your shift and you're getting introduced. It's okay to say, hi, I'm Leisha. I'm going to be your nurse until tomorrow morning, and I am incredibly sorry that you're going through this. I am sorry you lost your baby, or however you need to phrase it. And it's important for you to think about how to do this prior to going in. You don't want to go in and find yourself off kilter and stumble through something. You want to say, I'm here to support you and to, help you make decisions and, to make sure that you are recovering okay here, right? So you're acknowledging your role, you're acknowledging your presence, and you're acknowledging their loss. Really, really important when we're dealing with these families to try to provide as much privacy as possible. We do not want them next door to the noisiest baby on the unit. We also want to keep laughter in the hallways down or at the desks down. So we want to have a muted mood, especially because sometimes a family member will leave a room, and remember their life at the moment is full of devastation, right? And our life at the moment is a shift as normal. And so we really want to make sure we're communicating with our peers that we have a loss on the unit and that it's inappropriate for us to be, really laughing loudly and being really animated at the desk, that especially when they exit the room, that we should have a little bit of muted respect, and that we should try to make that as unawkward as possible for them. It's important to post a sign on the Stafford door. Up on our unit in Great Falls here, there is a special, like a flower, and it's just like a laminated little flower, and it has like a lily, and it has just a little piece of something that sticks it, Velcro, I think, next to the door. And that's important to train all of our new staff, to train our new dietary, to train our new laundry people, whoever housekeeping may be on the floor. It's important to train them that means there's been a demise or a loss in that room, because that does inform how you approach when you walk in. You're not going to walk in all jolly and be like, and how's your little one? And then feel awful, right? Because they're in an awful situation. It's crucial to also provide pamphlets and resources. We oftentimes, in addition to encouraging holding the baby, we provide a little kit. And in that kit is some information about how to deal with loss, and we put in some information about the baby and the photos that we take as staff. And I know Amber has a great presentation that some of you have seen on how to take photos and how to focus in on demised infants, and how to make sure you provide a photo that has color in it aside from black and white. And we as staff used to always take those. Now we have a photographer who will also come in and take some of those photos for us. But if they're unavailable, then it still falls to the staff to do that task. And with that, there's a little booklet, and it's called When Hello is Goodbye. And then I oftentimes will also provide information for Peace Hospice. Peace Hospice provides resources for anyone in town who has had a loss of any kind. So when there's a death, whether it be a fetus or whether it be a newborn, an infant, a child, they offer some great resources as far as reading materials, professional counseling that's done for free, and resources as far as support groups and things like that families can access to help them grieve healthily. And especially when you're looking at families that have other children, and these children have expected a new sibling, those kids are going to have a whole different set of issues, and they actually provide counseling specialized for children and teens who are experiencing loss in their families. And so when you go into the room and as you're preparing the baby and that sort of thing, we have that memory box, and I do have one in my office if you'd like to come and see it. We oftentimes will, if there's the ability to, we'll clip a piece of hair. We'll put the hair in a little Ziploc baggie and have that in there on a card. We'll also do foot castings where we actually do little feet molds with the baby, and then we do the plaster and create a little kind of almost like an ornament or a little wall hanging for them. We put in a baby hat that's appropriate to the baby's size, possibly a diaper. And then of course there's a sympathy card that we send as a staff, and so we oftentimes, if you're the delivery nurse, we'll actually sign that card, and then our secretaries will mail it out, a month after, just to say that we're, still thinking about them and sorry for their loss and things like that, and to encourage them to reach out if they're having any difficulties at all. And then I really do recommend, and this is for all areas, not just OB, but I recommend a book called Tear Soup. It's a picture book, and then there's a website here. It's called griefwatch.com, and they have a video about Tear Soup, and it's really about how families process grief, and kind of how if you don't process grief, it sits on the back burner of the stove and it burns, and then you have to restart your Tear Soup. And so it talks about, when is the appropriate time to be putting your Tear Soup in the freezer, and when do you pull it back out and kind of take a taste of Tear Soup again, and that might be, at the 1 year mark or at the 1 month mark, and that sort of thing. And so it's really a great way to start a dialogue with just about anybody about grief and loss. It's a powerful little video, a powerful little book, and it's always on my highest recommendations of something to familiarize yourself with as a nurse, as it's appropriate in just about every situation. Okay, so that pretty much wraps up my lecture on postpartum complications and unbound demise, which is important to at least know about or touch on. It is important as well with all of these areas, when there's complications, to also look out for any staff that you have that may be pregnant or expecting. And we do know that any of these situations can be traumatizing to all of us, but it can be especially traumatizing to a nurse who is expecting, and it can be traumatizing to a family who also has a pregnant nurse, especially if there's a poor outcome. And so I really do recommend that we look out for one another, and that you plan your staffing accordingly and make good judgments.